we can put. 20 gauge and 18 gauge is usually suitable for IV access in adults. For trauma patients or where rapid IV infusion of fluids is required, a 16 gauge or a 14 gauge is what we want. We need to have a good reason to use a large bore IV now. We don't just stick 14 gauges in people who are drunk. That can constitute battery. We don't do it just to harm people. We only do it if there's a legitimate reason for needing that large bore access. 22 and 24 gauge is for our patients who are pediatric or who have extremely small or fragile veins, like our elderly patients or my wife. When you set up the IV fluid, we want to make sure that the fluid bag has the correct name of the fluid on there. We want to make sure we have the right fluid, check the expiration date, make sure that the bag is not damaged, there's no leaking, make sure that the fluid is clear, there is proper color, and no visible contaminants. Don't let the sterile portion of the tubing come in contact with anything other than the inside of that IV bag. These are your basic sites for your venous access, peripheral sites. Remember, we start distal and work our way proximal, so we want to start looking in the hands here and then work our way up towards the antecubital space. This is the basic venous anatomy, but everybody's veins are slightly different. So every patient you encounter is going to have a slightly different venous anatomy than the one before that person, but they're generally in the same areas. The back of the hand, the forearm, the antecubital space, and those are all good areas. On the lower extremities, we can start at IVs in the peripheral areas. In Louisiana, we do not have this ability to do EJs. They took that away from the advanced EMTs. Whenever we start an IV, we want to make sure that the needle is pointing in the direction of the blood flow towards the heart. We want to apply the venous tourniquet to restrict venous return, and we're going to engorge the vein. We don't, of course, if you go move to a state where you can do an EJ, don't do this to the jugular vein. It's already big enough. No need to wrap a tourniquet around the patient's neck. Use very prominent superficial veins that are readily visible, and deeper veins if you can. The veins should be spongy, have a springy type feeling on palpation. It shouldn't be hard or rough, and it shouldn't be very small or fragile. It has to be able to fit the catheter. Disinfect the site and hold the needle at about a 45-degree angle or less to the skin with bevel up. Of course, line up the direction of the needle with the direction of the vein. Once you puncture the vein, you'll get flash in the chamber. You're going to lower the angle to about 15 degrees and advance the catheter slightly, probably about no more than a couple millimeters, and then advance the catheter into the vein. Never pull the catheter back over the needle or advance the needle through the catheter. That can cause a tear in the catheter, and that tear can become an emboli and cause the patient to have a heart attack or stroke. This is the equipment that you would need for setting up an IV. Here's your tourniquet or your constricting band. Here's your 18 gauge, or I'm sorry, your 20 gauge IV catheter. Here's a alcohol prep. This is your normal saline flush, 10 cc's. Here's 1,000 liters of fluid. Here's your IV lock set, your 4x4. This is a VeneGuard. This is for securing the IV in place, and here's your drop set. Check the name on the fluid, inspect it for clarity, and make sure it's not expired. Hold it up to the light. Disconnect the pigtail. Close off the clamp on the IV tubing. Remove the protective catheter over the IV tubing spike, and then push it into the bag while the bag is hanging down. Once it's in the bag, you're going to squeeze the drip chamber until it's half full. You're going to squeeze it and then release it, and then it should be about half full. Then you're going to release the roller clamp and bolus out all of the air. You want to make sure that there's no air in the line, so allow fluid to go down through the drip set here and get all the air out. If you don't get the air out, you'll kill the patient. Tie the constricting band on the arm. Prep the site in a circular motion, just like that. Insert the catheter, wait until you get flash, and then drop your angle to about 15 degrees, and then enter into the vein just slightly. Advance the catheter while keeping the catheter in place. Basically, what I'm saying is don't pull the needle back, advance the catheter forward. Release the band. Never let go of the hub of the IV catheter. Connect your lock set to the catheter, and then flush the line and ensure that you have patency and no infiltration. Secure the IV with a commercial securing device or tape, and monitor the patient. Now, a lot of unsuccessful IV attempts will occur because veins move away from the needle. A lot of times what you do is you'll pull traction on the skin to prevent the vein from moving around. If the vein moves, you may have to pull back on the needle while keeping the catheter over the stylet, not advancing the catheter, and then pull back a little bit and then advance again. Try not to make a bunch of repeated attempts. Each time you reposition the needle, you're going to cause pain to the patient. Some people will refer to this as fishing. Sometimes you'll puncture both sides of the vein. If that happens, you'll blow the vein and you'll have the blood start to leak in. That means the vein's no good. We have to abandon our attempt on that vein. Sometimes the catheter will meet resistance from a valve. What we'll do is we'll attempt sometimes to push some normal saline and hope that the valve will open up. And if we can get the valve to open up with some normal saline, then we can sometimes advance the catheter through. And then sometimes our angle of insertion is too wrong, either too shallow or too deep, and we puncture the vein and blow it. If the vein is blown or for whatever reason we have to abandon the attempt, remove the IV catheter and dispose of it safely, and then apply a 4x4 dressing to prevent bleeding. If you already attached a saline bag, make sure that you clamp off the bag so contaminated fluid doesn't leak all over your ambulance. Never let a bag completely empty. If you let a bag completely empty, you're going to have to change out the line because you're going to have a lot of air in the line. So when there's only a few millimeters of fluid left in the bag, you can go ahead and clamp off the IV tubing. Close the roller clamp to prevent any fluid from entering. Spike a new bag and make sure the drip chamber is 1/3 to 1/2 full, and then readjust the flow rate. So anytime we break the skin, we have a risk of infection. So we have a risk of infection if we don't properly clean the site. We can have infiltration that occurs when the vein is injured. That means IV fluid or medication can leak out into the interstitial space and cause pain and swelling. We can have air embolism that can cause cardiac arrest and death. We can have bruising or hematomas in patients, especially elderly patients or patients who are on blood thinners. That's common. We can have phlebitis. That's inflammation of the vein. That can be caused by infection from either infected or contaminated IV fluids or medications. Sometimes we can activate the clotting cascade by inserting an IV. We'll have thrombophlebitis, which basically is the IV catheter becomes clotted. You'll have redness and inflammation and pain on flushing the line of the IV. We can have a pyrogenic reaction. A pyrogen is any kind of foreign body that comes into the patient. Oftentimes, you're going to have a sudden flu-like symptom. Sudden onset of flu-like symptoms after the IV administration. So sudden onset of fever, chills, backache, headache, nausea, and vomiting, and then sometimes shock can occur. If you have a pyrogenic reaction, remove the IV and then start another IV in a different location with different equipment and different fluid from before. Don't use the same lot number because there may be an issue with that lot number. And then we can also have fluid overload. That's a risk anytime we give patients fluids through IV, especially patients with weaker hearts like congestive heart failure. Anytime we give fluid every 250 to 500 milliliters, we want to reassess the patient's lungs and make sure that they're still clear. If we start to hear fluid build up in the patient's lungs, that means that we need to back off of the fluid and discontinue it. The patient is now in fluid overload. Some signs of fluid overload: shortness of breath and crackles. If we have that it means that we have significant fluid overload. Like I say, every 250 to 500 milliliters, we want to reassess lung sounds and look for edema in the feet and hands and arms. So this is an easy IO. This is how we gain, one of the ways that we can gain intraosseous access in a pediatric patient. We have 3 different needles here. We have a humoral needle, we have the adult needle, and we have the pediatric needle, which is the one that we're going to be using. That thing that we just saw was an Easy IO that's created by VitaCare. There's also the bone injection gun. We also can do manual access. That's what you'll be tested on at registries, manual access. If you can't find any anatomical landmarks, never attempt an IV, or rather an IO, because we can damage the patient's legs. So this is the equipment that we'll need for intraosseous access in a pediatric patient. We're going to need a fluid bag. We're going to need the tubing. We'll need gauze here to stabilize the site, some tape to secure the gauze to the patient. We're going to need the needle itself. We're going to need some. We're going to need the drill. We're going to need tubing, the flushes 4x4, and then preps to clean the site of insertion. In the pediatric patient, the proximal tibia is the preferred site. You can see that they're going to the medial aspect of the proximal tibia. If you palpate on top of your tibia, right beneath your patella, you'll find some ridges right there, just beneath your patella. Those ridges are what's called the tibial tuberosity. We're going to find the tibial tuberosity, slide our fingers we're going to go about 2 finger lengths beneath the tibial tuberosity, and about 1 finger length to the anterior medial surface of the tibia. It should be a nice flat surface. You should be able to feel it on your tibia right now if you're palpating that area as I'm talking. Make sure you're using the correct needle length for the patient. In the Easy IO, the correct needle is going to be the pink needle. For the manual IO, use the pediatric manual IO. Clean the site either using alcohol preps or iodine swabs. Notice this here, that he's supporting the site with just some roller gauze to make sure that the site doesn't move. It's going to use aseptic technique and place the needle in the driver here. Going in at a 90-degree angle, going to insert the needle through the skin until the needle makes contact with the bone, and then drill into the bone. After you drill into the bone, you're going to remove the stylet. You're going to attach a pre-filled tube and flush normal saline through. Observe for free flow of fluid in the absence of infiltration in the soft tissues. Do not aspirate. And then attach the IV tubing and adjust the flow rate as needed. Secure the device with padding, just like you see here, to make sure that it doesn't move, it doesn't hit anything, keep it stable. And then attach an armband with the date and time that you put, or a leg band with the date and time that you put the device in. So complications of IO attempts is incorrect placement due to improper identifications and landmarks. We can actually cause pediatric patients long-term problems with incorrect placement. You can actually damage the growth plates if you're not careful, and that leg will be short and will no longer grow. Obstruction of the needle sometimes, if you attempt to aspirate through the needle to make sure that you have placement, you can collect little bits of bone into the needle, and the needle won't flush anymore. If there's a fracture in that site, don't insert the needle. If the leg is infected, do not insert the needle. If you may have compartment syndrome due to improperly placed needles, which can infiltrate into the muscle tissue. You can also cause infection and fractures by putting too much pressure on the needle itself. That will cause a fracture, drilling too forcefully, or an infection by making sure that by failing to clean the site properly. And you can also have a fat embolus. You can actually push fat into the vasculature. Some common contraindications to IO insertion include fracturing to the extremity. You've already tried to insert an IO in that same bone. And then the patient may have a disease called osteogenesis imperfecta. Basically, it's a brittle bone disease, or osteoporosis, or there's an infection over the inside of the insertion. And never place an IO through burned tissue unless you have absolutely no other option. And then never place an IO if you cannot determine anatomical landmarks. IO insertion is not considered something that we do prophylactically. This is something that we do if we cannot obtain an IV for whatever reason, or the patient is, depending on your local protocols, or the patient is an extremis. Usually, though, in most areas, they require you to at least attempt 2 IVs before you attempt an IO insertion. Remember, this is not something that we just do prophylactically. We don't just do this just in case. We have to have a very good reason to start IOs.